So, continuing with CNVMs and vascular diseases of macular, looking at retinal angiomas, that are having financial disclosures to me. Retinal angiomas proliferans. There is a variation of an AMD which you notice in these patients where they look more like a CNVM. There is a mild variation which you see. First point by Januzzi. You see this variation in about 20% of AMD patients, which you see is more common in white people when compared to our population. So what exactly happens in retinal angiomas proliferans? So what happens here, if you look at this, the first slide, this is a slide taken from publication by Januzzi. So this is where the retinal angiomas proliferans starts. So it starts inside the retina, not in the choroid, and it starts progressing into the retina, goes into the subretinal space, goes into the subretinal space, causing subretinal fluid, causing a pigment epithelial detachment, goes into the sub-RP space, and finally forms a choroidal anastomosis. So that's what happens at retinal angiomas proliferans. Whereas regular choroidal neovascular membrane usually starts from here. It goes to the subretinal sub-RP space and go to subretinal space and then forms. But when you look at clinically, you might look almost similar, because if you look at this stage, you might see a difference. But if you look at this stage, you might see almost same. But there are a few things which you look at closely, then you might be able to identify this as a different variation. So stage 1 is usually an extrafoveal, asymptomatic. You don't have patients coming with a complaint, but when you examine these patients, the earliest sign is a cluster of intraretinal capillaries which you might see. You might see a small red dot there in that area. So if you do an angiogram, you might see a hyperfluorescent spot there in that area. If you do an OCT, you might see a hyperreflective lesion inside the retina and nothing else. So the OCT is quite sensitive in picking up these intraretinal lesions. So whenever you are indoor, get an OCT done through that lesion where you are suspecting a hyperfluorescent spot. Stage 2 is where you see a subretinal growth, and you see a subretinal hemorrhage sometimes, and you see growth in the subretinal space. You might most likely miss this for a CNVM in this stage. But then again, when you do an angiogram, you might be able to pick up at that early hyperfluorescent spot in the angiogram, which comes inside the retina, and you do an OCT through that lesion. Always remember that if you do an OCT anywhere other than that area, you might get a subretinal membrane, you might say that it's a regular CNVM, but if you get the OCT done through that lesion, you might be able to pick it up. And stage 3 is where you have membrane going into the sub-RP space and then causing pigment epithelial detachment, fibrovascular PEDs, and choroidal anastomosis. So these are a few examples which I'm going to show where you see this is an early hyperfluorescent spot which is seen here, and which becomes brighter at the later stage, and see there is increased fluorescence in this area. That's where the CNVM is going, but this is one bright spot which is seen inside in the angiogram. You see a lesion which is starting inside the retina. You see a subretinal hyperreflective area, but along with that you see an intraretinal lesion, which is not usually seen in case of the CNVMs. Again, the same thing. You see an intraretinal fluid, you see an intraretinal hyperreflective lesion going into the sub-RP space. This is a typical example of OCT going through this hyperreflective spot. You see an intraretinal lesion going into the sub-RP space and going in the sub-RP space. This is another area where it is actually going in the sub-RP space. So that's something which you need to do. If you do an OCT here, you might not see, you might see only the subretinal lesion, sub-RP lesions. But you have to look at all the scans of OCT and look at this scan where it's passing through this bright spot. You might be able to pick that up and identify that. The reason why you need to identify this is the prognosis for these patients is not that great when compared to regular CNVM which you do in CNAMD. And the treatment, what we see is regular anti-VEGF treatment is these patients can trigger again and again. You may have to use multiple injections and a combination of TDT and anti-VEGF injections. But then at this point in time, we still don't have a clear-cut protocol for treating these patients. we still go for a combination therapy. If it's an early stage, if you identify these and you can always do a focal laser and then bind them off. And if you're in the later stage, in stage 2 or stage 3, try for a combination therapy. Thank you.